Good, good morning, my dear colleagues. Welcome to the session. And today we have several outstanding presentations from our colleagues all over the world. And the first speaker, Margaret Sarandon Chen, Good Microbiota and Pancreatic Cancer, Any Connection? Please.
So, dear chairs and delegates, I would like to thank the organization committee for the kind invitation to present in this great conference. My presentation is entitled Gut Microbiota and Pancreatic Cancer. Is there any connection? I'm Margaret Salberg Chen, and I'm a professor at Karolinska Institute. I'm a research PI, and I have no financial disclosure to share. So let's speak about gut microbiota and pancreatic cancer. Is there any connection at all? So during the last decade, there is a long line of evidence already suggesting that microbiome alteration is actually seen in pancreatic cancer patients. And interestingly, until some years ago, it was thought that the pancreas was a sterile organ. But the new evidence today, in fact, indicate that the pancreas can have an own local microbiome. And one of the many great studies was the one reported by Gelle et al. In 2017, where they showed that majority of the PDAC samples, in fact, had detectable bacteria. And they also showed in mouse studies that the local microbiome could interfere with cancer treatment in this experimental mouse model. And thanks to this and the many other elegant studies, we have realized that the microbiome profiling of tumor, fecal samples, and even saliva samples can have actually a powerful predictive value in evaluating the pancreatic cancer risk, including perhaps the treatment outcome. So, although the presence of microbiota in pancreatic cancer is recognized and accepted, it is still not very clear how the bacteria colonize the pancreas. The fact that the pancreas is connected to the digestive system is very true, and we have also learned recently that oral microbes can translocate and some can even survive the acidic environment in the stomach, and they may also travel with the portal vein and the lymphatic system to the pancreas. So indeed, we are living with our own microbiota, and virtually our own body sites are colonized by microbes. But we are not always aware that millions of microbes, oral microbes, are swallowed daily, especially when we eat and drink our food, and that our blood and lymphatic systems can also help carry them further to distal organs. On the top of that, most oral diseases, if we get that, also generate a dysbiotic commensal that can persist quite a long time, chronically, and even for a lifetime if not removed. And this, of course, can disseminate further. And this is of great concern and is regarded as a risk factor for systemic diseases such as cancer malignancies along the GI tract. And until a few years ago, we were not very convinced ourselves, but we started to realize the importance of the oral microbes until when we found a local microbiome in the IPMN, which are regarded as potential early precursor lesions to the invasive pancreatic cancer. So in this very nice collaboration with Marco De Chiaro's group, we co-discovered that surgically retrieved IPMN cyst fluid not only harbored a local microbiome, but also the biome size also positively correlated to the IL-1 beta and the lipopolysaccharide level inside the cyst fluid, which indicated the microbiome has translocated and it has taken place. And to our surprise, when we looked deeper into it, into the IPMN microbiome sequences, the classifications there indicated that there was an enrichment of oral microbes that normally should live in the oral cavity. And among them were the Granulicatella and the Fusobacteria nucleatum, which had previously been associated with invasive pancreatic cancer. And now we found them again already present in the early stage high-grade dysplasia cases. And the bacterial DNA were detected again in the FFPE tissue samples. So our analysis then further indicated that the microbiome, this microbiome appeared in a biofilm-like constellations within the patient samples in this typical co-presence and mutual exclusions. And this suggests that they maybe could have been jointly translocated into the pancreas. And this is interesting because the pancreas gland and salivary glands, they in fact share many similar functions, both physio and biochemically, as they produce enzymes that help us to digest our food. So possibly this resemblance may help to support this type of bacterial community. So for us, at least, the connection of oral microbiome and pancreatic cancer is getting more and more clear. The large population-based studies already firmly suggested the long and very strong linkage between periodontitis, the gum inflammation, and pancreatic cancer. And the bacterial carriage of oral pathogens and also large antibody prevalence studies confirmed from different continents, US and Europe, also confirmed this link. And experimental mouse studies by Pushakas and Ayukut's group both reported that oral feeding with tracer labeled gamma proteobacteria such as E. faecalis and E. coli, or even fungi, could lead to relocation of bacteria to the pancreas tissues with a very short time, in fact. But then let's keep in mind that through millions of years of evolution, our immune system has been trained by our microbiota and the infections that we encounter. And the many types of infections, of course, should then challenge the immune system so that it can be ready to recognize our what's self and non-self, and what should be inside and outside our body. So it's job to recognize and remove the intruding, invading pathogens. So we therefore hypothesized that IPMN patients perhaps could have an pre-existing immunity already to these oral microbes that we found in the wrong side of the body in their pancreas. So we performed the antibody analysis in a patient with IPMN, and in fact, we found the patient with IPMN showing high-grade dysplasia and invasive cancer, that they also showed an elevated antibody response to the oral bacteria in both saliva and the serum, and they were in both IgG and IgA isotypes, and found in both saliva. So this then led us to the next step. In the literature search, we saw that there were metabolomic studies that already indicated that metabolomic changes and analysis can discriminate IPMN and the grade of dysplasia associated with IPMN. But we did not know if or how the metabolomic alterations that we saw there were related. So here we performed a deep untargeted metabolomic analysis of IPMN cyst and pair serum samples, and asked if the microbiome had a connection there. And in this deep metabolomic analysis we did with Dr. Angelo De Alexandro's laboratory, we found metabolomic changes inside the cyst fluid of IPMN were highly correlated to the cystic bacteria quantity. And this involved a large number of bile acids, as well as the cavadarine and the putrescine, which are known derivates from the microbiota metabolism. So hence, this observation told us the IPMN microbiome is actually alive and functional, and maybe there is an infection going on here. And because the microbiome studies, they mainly focused on DNA analysis, we did not know if the DNA came from live or dead bacteria. So we made a huge effort to catch them alive. And so we could perform functional studies in the laboratory. So by using the latest proteomics technology, the multi-TOF mass spec instrument, we could classify these live bacteria into the strain level. We then utilized the 2D and 3D co-culture systems with different type of pancreatic cells. Here to the left, by FACS analysis, we found that some of them were actually capable, some of the bacteria were actually capable to infect and hide in the pancreatic healthy cells and cause cell damages and deaths. Interestingly, the cells that survived demonstrated the clear DNA damage. And this is indicated by a marker called gamma H2AX, and is a typical sign of early cell transformation, as can see by the UV irradiation controls. So in further collaboration with Matthias Söller's group, we are investigating this further in several tumor spheroid models to try to understand the genotoxic potential of this bacteria. And we also found that pre-treatment of antibiotics in the co-culture could actually help to prevent the DNA damage, but clinically this isolates actually came from antibiotic pre-treated cases. So we are not sure if the antibiotics actually had sufficient clinical effect. So in conclusion, I would like to say that the growing amount of evidence does suggest the microbiome and pancreatic cancer is not merely a connection or association, but rather a functional process where a local microbiome possibly derived from an opportunity or colonization is there and capable to promote and maintain the tumorigenesis. By this, I would like to thank my team members and collaborators for their excellent work and the generous sponsors for making our work possible. Thank you very much.
Thank you very much for your nice presentation. Are there questions? I think in the chat there are no questions. Where do you think is the future in your field?
Yes, thanks very much. It's the future. Well, we are actually trying to see, trying to look deeper into this tumor bacteria, the live ones, and we would like to see exactly how they cause this double DNA damage. And we are looking forward to collaborations and in spheroid and organoids, and see if there is a more consistent effect, and not only in the conventional 2D assays.
And where do you see problems in this field?
In this field, well, I think maybe more basic researches are needed, because we don't know if the tumor microbiota, the live one, we don't really know where they really come from. Of course, a lot of studies do take stool samples and gut samples, but how do they actually come more upstream, and where do they acquire this genotoxic effect, the virulence genes? We don't really know so much yet, and we are thinking maybe that if it is more up in the upper GI, maybe there is also some opportunity there. Maybe this can be the risk factors can be modified by a lot of interventional approaches.
There's one question, I don't get it completely, but it's about how can the microbiome might be changed by antibiotics or probiotics? Because microbiome is always a little bit very variable situation, because I think it's also changing depending on your lifestyle. If you are changing your lifestyle, if you're changing the food, maybe everything is a little bit altered.
Right, true. That's very true. And I think I would also like to remind that we also have an immune system in our body that is co-living with the microbiota. Of course, that will also, if we can help them to try to catch up, because they also immune cells can recognize microbiota changes, metabolites, and so on. Immune cells, for instance, mate cells, those maybe can be alternatives to antibiotics, given the resistance. Antibiotic resistance is actually is of concern now today. So maybe by enhancing the immune system will be something to work further on.
Thank you very much.
Thank
we have to
Just very quickly, sorry, I jumped in. I was at the council meeting. I have a question for Professor, very quickly, 30 seconds. For IPMN, I'm very interested because we are striving for reliable biomarkers in the cyst fluid. Do you see a future for microbiota in this regard? Because we know that they have to be not just reliable, but also cheap. Would it be possible in your opinion? I'm very interested in that. Thank you very much.
Very short, because
yes,
we are
I think that's
over time.
Thank you very much. It's a very good question. I think because we have our clinical collaborators, they also take with endoscopic samples. It's possible that use those volumes. It's possible to try to look for microbiome related metabolites and DNA and bacteria. Then.
Okay, thank you.
Thank you. Thank you.
So I think we have to go on, and the next presentation is from Dr. Chiot about neuroendocrine tumors of the pancreas, sporadic or MEN1. Which difference, please?
First, I would like to thank you for being here with you, especially in this very special time for Ukrainian people, and we are all behind you in this difficult moment. We're going to discuss in the next minutes on neuroendocrine tumor of the pancreas and what are the difference between sporadic and MEN1 patients. Clearly, first, remember that sporadic tumor represents more than 95% of tumors. And familial syndrome, mainly MEN1, represent less than 5% of those tumors. What are the similarity and difference in those tumors? They will concern first the patients, but also the tumors. Regarding the patients, just remember that for MEN1 patients, those patients are really younger, since the disease starts to be symptomatic most of the time around 20 or 30 years old. And at this time, quality of life matters. And you should remember that when you planning a pancreatic surgery. For sporadic lesions, they occur usually between 50 and 70s, when patients start to carry comorbidities. And also those comorbidities should be taken into account when you're planning, as example, a Whipple. But there is also what we can call comorbidities in MEN1 patients. MEN1 is usually the 3P, parathyroid, pancreas, pituitary, but it's the 3Ps, in fact, since there is several other affected organ. And bronchial and thymic one with their neuroendocrine tumor should also be taken into account, since even if they are rare, will greatly affect when they occur the patient's survival. Remember also that in MEN1 patients, those patients carry a very high likelihood of surgery, above 95% after their 70 years. And most of patients will be operated at least twice during their lifetimes. Also remember that the overall survival of MEN1 patients is significantly decreased compared to the general population, with a lifetime difference of about 50 years. When you're looking at the tumor, there is the non-functional pancreatic neuroendocrine tumors and the functional one. In MEN1, the non-functional represent about 3/4 of tumors. After there is the gastrinoma and more rarely the insulinoma. And those various tumors can coexist in MEN1 patients. And the issue is to determine who is who. For non-functioning pancreatic neuroendocrine tumors, what is similar? First, size is the main prognostic factors. And with size, risk of nodal and distant metastases will increase, with a clear cutoff at 2 centimeters. So just remember that for lesion above 2 centimeters, the nodal, the risk of nodal metastasis is about 10%, and thus justifies surgery with formal lymphadenectomy. So when you're thinking of parenchyma sparing preserving that will preserve the quality of life, or standard pancreatectomy, which is a non-chirurgical procedure with lymphadenectomy, those should be favored most of the time. For lesions below 2 centimeters size, if they are asymptomatic, observation is an option, since that will not affect the patient overall survival. But this is under strict conditions. You need to have a proven diagnosis, you need to have a complete workup, and you need to have a possible follow-up in those patients. So just remember, what is similar in MEN1 and sporadic lesions, observation is possible for asymptomatic non-functional peanuts below 2 centimeters in size. Surgery should be the rule for all other non-functional peanuts. And when it's possible for lesion between 2 and 3 centimeters, with at least a length node speaking, parenchyma sparing procedure might be possible. So there is clearly very few difference in the surgical management of MEN1 and sporadic non-functional pancreatic neuroendocrine tumors. Looking at the functional pancreatic neuroendocrine tumors, just remember that the only emergency is the symptom treatment that will kill the patients very quickly. For gastrinoma, PPI clearly controls symptoms in more than 95% of patients and should not be stopped, should never be stopped, even for gastrin dosage or so. For insulinoma, you can use diazoxide, frequent meal, education, but clearly you should try to control the possibly deadly hypoglycemia. First, discussing gastrinoma. About 1/4 of gastrinoma occur on MEN1 patients, and about 1/4 of MEN1 patients will have a gastrinoma. Gastrinoma is still a frequent cause of death during MEN1, and they represent about 20% of deaths, even after the 90s, with the widely availability of PPI. What is similar between sporadic and MEN1 gastrinoma, that they are all small lesions, preferably located in the duodenum, in the stabiloid and passaro triangle. Their secretion is nowadays very well controlled by PPI. So it's no more a secretory issue, it's an oncological issue, with an overall survival of more than 10 years in most of patients. That should be kept in mind when you are going to perform a surgery. What are the differences? The differences is that in MEN1 patients, gastrinoma are always multiple. And cure is rare if they except if you're performing a pancreatico-duodenectomy. So consequently, the surgery should be more selective in MEN1 patient than for sporadic lesion. And surgery is only considered for lesion above 2 centimeters in size, or for lesion with nodal metastasis, or if a familial past history of aggressive gastrinoma is present. For gastrinoma, which surgery? You can do a limited surgery, duodenotomy and lymphadenectomy, which is the Ann Arbor-Thompson, eventually distal, the Ann Arbor-Thompson procedure, or a pancreatico-duodenectomy. When you're performing the duodenectomy, you find usually quite a few of gastrinoma, and you should add the lymphadenectomy to increase the survival of the patient as it has been shown in sporadic lesions. When you're doing a Whipple, just remember that Whipple for gastrinoma has been, of course, published with very short series, like 22 patients. This clearly, compared to a local procedure, will increase disease-free survival, but with no impact on overall survival. Keep that in mind, and with very few published data. So clearly, for gastrinoma, MEN1 and sporadic one, PPI is key. In MEN1, lesions are multiple, have a better prognosis, cure is rare, and surgery should be more selective. Which surgery? A local surgery or Whipple is clearly not determined yet. Next, Sulinoma. There are 10% of Sulinoma will occur in MEN1 and 10% of MEN1 will have Sulinoma. And those Sulinoma can be located everywhere in the pancreas. What is similar? Sulinoma are always in the pancreas. And this is a secretory endocrinology issues, because clearly those patients will have very few metastases from their Sulinoma. What is key is the tumor locations. But with EUS and CT scan, you have a very high nowadays sensibility and specificity. But in Sulinoma, when it's from inoccurring MEN1 patients, lesion can be multiple. And the key is to localize the lesions and to know which pancreatic tumor or neuroendocrine tumor is secreting. For that, extended PET CT scan clearly helps us determining which one is the Sulinoma. The best treatment, of course, for this lesion is enucleations, but you need to know that Sulinoma can be multiple in MEN1. So are you doing multiple enucleations or distal pancreatectomy and an enucleation? This has long been favored because the recurrence rate was lower, as published in the French cohort. But is it still true in 2022? I'm not sure. And with the extended PET CT scan, enucleations and even multiple enucleation, in my mind, should be the best treatment for those MEN1 patients with Sulinoma. Just remember, Sulinoma and MEN1, they are always, as in sporadic patient, pancreatic with an excellent prognosis. The difference is that there are sometimes multiple. If enucleation is the best treatment for sporadic lesions, the best one for MEN1 patients remain to be determined. So to conclude, just remember when you're comparing sporadic and multiple endocrinoplasia type 1 pancreatic neuroendocrine tumor. They occur in younger patients. They are most of the time multifocal with a higher T stage. So you need, when you're deciding, understand that factors influencing PNET management are numerous. They include locations, the risk of metastasis, the grade of the tumor, the heredity, the patient's condition, the function, and secretion. And clearly, when you're dealing with those patients, multidisciplinarity and medical knowledge are requested. Remember that if God put the pancreas in the back, it was because he didn't want surgeon messing with it. So always stay humble in front of a pinnet, and especially a non-functional pinnet, because sometimes you might be more dangerous than them. Thank you very much for your attention. Thank you very much.
Thank you.
Merci beaucoup, Sebastian. Great overview. We really enjoyed. We have to be very, very tight with time. So I saw there is already a question to you. My quick one would be, I mean, the real deal now, Sebastian, is not on who we should operate on, but those who are under observation. So I'm talking about the sporadic non-functioning less than 2 centimeters. What is your experience? Because we're all waiting for the Aspen trials results. But in the meantime, I mean, what's going on with the small pinnets that you are under surveillance? That's a very hot topic. Thank you.
Most of them are doing very, very well, and most of them never evolve or never grows. The big issue is that we don't have a huge follow-up for those patients. The main series is a follow-up of less than 5 to 10 years. That means that in front of the life expectancy of these patients, there is clearly a lack of data. So I'm continuing to follow them, but we still know that duodenopancreatic tumors is the main cause of death in men 1 patient. So we should continue to follow them, but knowing that at 10 years, 20 years, 30 years, we don't really know yet what's happened.
Thank you very much. Igor, to you.
Thank you for your great presentation. I have one question. My question, what kind of neuroendocrine tumors has worst outcome?
Oh, clearly, it really depends. For Sulinoma, they almost never metastases. The gastrinoma, nodal metastases are quite frequent, and even sometimes liver ones. But anyway, even with those metastases, the prognostic is quite good, with an overall survival of more than 10 years. Same for non-functional tumors, like when liver mets occurs, those patients can stay alive for more than 10 years. So it's really depends according to each tumors. Clearly, the very rare one, such as sometimes glucagonoma, can occur in men 1. Those are very rare, but clearly carry the worst prognosis. But really, that the big issue in a neuroendocrine tumor, that there is a very high variability within 2 tumors. But clearly, what changed the natural history of those patients is the appearance of liver mets.
Thank you very much. The next speaker, Alexander Usenko, Director of Kyiv National Institute of Surgery and Transplantology, surgical treatment of malignant periampullary tumors.
Dear colleagues, it's an honor for me to give a small talk in front of such respected audience. Unfortunately, we are unable to host the conference in Kyiv due to full-scale war with Russian Federation. We hope to welcome you soon in peaceful Ukraine after our victory. Despite low mortality and the modern era, pancreatic duodenectomy remains associated with considerable morbidity, with an overall complication rate ranging from 20 and 65%, even in the high volume center. Adverse outcomes following PD stem from three broad factors: sojourn and hospital volume, disease pathology, and patient with comorbidities and frailty. Despite the advantage in surgical techniques and preoperative therapy and 5-year severe rate for patients with periampular tumors remain low. For last decade, the basic major milestones in pancreatic surgery, Prology 24, trial and FOLFIRINOX regimen. We observed the changing of paradigm in expanded lymph node dissection, adoption, and minimally invasively pancreatic surgery. The acceptance of after first approach and the concept of total mesopancreatic excision and worldwide erupts in implementation in PD patients. The first major advance I want to mention today in presentation by Conroy and colleagues in 2019 result in Prodigy 2.4 trial with showed an impressive increase in disease-free severe and will to an increase median overall survival. Nowadays, the FOLFIRINOX is already in standard of care. Adjuvant therapy is common approach in patients with resectable disease after resection. However, is becoming increasing approach that patients with borderline resection disease who are at high risk for R1 resection are potentially is in need of the different management approach. Contemporary approach in the preoperative treatment have focused on neoadjuvant therapy for patients with borderline resection disease with a goal of improve overall severe. Neoadjuvant therapy is also something used in patients with resectable disease, especially is those with high risk future. Another here is on high level evidence upfront resection is patient with borderline resectable disease is not longer recommended. The next milestone pancreatic surgeons have passed in the concept of extended lymphadenectomies is PD patients. First general agreement of the definition standard and extended pancreatic duodenectomy was reached in Castelfranco, and the last definition of publication is 2001 in ICPS. And a lot has changed during this period, especially after Numira publication result of his trial as concludes as extended lymph node dissection could not improve the long-term result. So nowadays, ICPS definition, the standard lymphadenectomy volume from pancreatic heart cancer is widely used and includes just the following lymph node station showed on the slide. After venous resection were recognized to be safe and feasibly improving long-term outcomes, the focus has shifted to the superior mesenteric artery, and resectability is now dictated by whether or not is it involved. So after first approach, he's come to mean that the artery is given primary place in determining resectability and that in trail dissection and directed towards the early determination of whether there is arterial involvement before coming and in irreversible step in operation. The measure of studies in investigation margin status after PD shows that the positive CMA margin was independent negative predictor of severe. The CMA first techniques might also add to the safety of venosus resection, but the evidence of its effectiveness still price it in terms of influence of R0 resection in incidence and need more data. As well as the concept as a mesopancreatic resection introduced by the Ines Gogol in 2007. The main purpose of this procedure is to ensure posterior margin clearance and that to avoid positive R1 resection. Despite the controversy, the clinical appliance of the techniques show the improvement in R0 resection rate in some study, but we still need to cleanly defend the target group will benefit from this from a surgery. In our practice, we also use the techniques of periampular tumors and borderline resection, pancreatic cancer, coming with venosus and arterial resection. In prospective study, we reactivated comparatively early postoperative result of standard and so-called extended pancreatic duodenectomy in terms of our morbidity, mortality, and light of hospital stay. The overall survey and 21 and 28 months in expanded is standard resection, respective. The difference did not reach statistics significant. Minimally invasive pancreatic surgery becomes more common around in the world in the specialization and due to the favorable result, a severe, large, randomized controlled study such and Padula trial and plot trial, and if not to take into account Leopard 2 trial. In our institute, we have humble experience in laparoscopic PD, but the number of these procedures increase. Despite learning curve, this result are quite promising and showing some advantage in our mobility and light of hospital stay. RAPS programs gaining more support among pancreatic surgeons for the last decade. There are now numerous ongoing trains on the world. We study in the PD protocol for RAPS in 2014 and the running. We study of fast track program for pancreatic duodenectomy. Already published some result comparing standard treatment with a RAPS protocol patient and currently studying reconstruction modifications such as Brown anastomosis and waste increase the implementation rates. The results promising or terms reduced the number of complications, lives of hospital stay, and as a result, the cost of treatment. In conclusion, despite the progress, this is still much to be improved in terms of patient severe. Today, the common trial pancreatic cancer by surgery alone, but still the only challenge for CAR in resection. One day we will reach in limits of surgery, and the future perspective will be only by the personalization treatment with genomic driven practical medicine. Thank you for attention.
Thank you for your great presentation. And now he is absent. He is busy because of military affairs. And
So we cannot discuss his presentation.
yes. And please, the next speakers. The next speakers, Seheye Satoi, surgical treatment of metastatic pancreatic cancer.
Thank you very much. Can you hear me? Thank you very much. Can you hear me?
Yes.
Good. So thank you very much for chairman and organizing committee for inviting me to the distinct meeting of EPC 2022. So I'm always with the Ukraine and Ukraine people in my spirit. So please start my lecture presentations, video presentation. It is my great honor and pleasure for giving me an opportunity to talk about surgical treatment of metastatic pancreatic ductal adenocarcinoma (PDAC). My COI is exposed in this slide. Systemic chemotherapy is the standard treatment for patients with metastatic PDAC. It's been reported that for Phenox or GNP regimens can significantly improve the median survival time of patients with metastatic PDAC with a high response rate. In this situation, there has been no international consensus concerning the role of surgical management of metastatic PDAC so far, which can be classified in upfront surgery for oligometastases and conversion surgery after much moderate treatments. The most frequent site of metastasis in patients with PDAC is the liver, followed by the peritoneum, lungs, and so on. Herein, we focus on surgical treatment for PDAC with liver metastasis and peritoneal dissemination in this presentation. Conversion surgery is an additional surgery during much moderate treatment in patients with initially unresectable PDAC, but no planned surgery following neoadjuvant therapy in patients with resectable or unresectable PDAC. Surgical indications for metastatic PDAC in our institution is as follows. Metastatic lesions disappeared on CT imaging, no or less than 3 metastatic lesions on staging lab, downsized primary tumor, and decreased the tumor marker. We have treated 468 patients with unresectable PDAC from 2006 to 2017, and ULM was diagnosed in 360 patients, 77%. Among them, only 15 patients, 4.2%, underwent conversion surgery in my institutions. Survival curve in patients with the ULM was similar to that in ULLA. Median survival time in ULM reached at 29 months from the initial treatment. In summary of publications for conversion surgery in patients with initially unresectable metastatic PDAC, resectability in patients with liver mets was less than 5%, but a median survival time reached at 34 to 56 months. Resectability in patients with peritoneal dissemination was approximately 20% high because of strict patient selection, and median survival time reached at 26 months. Additional surgery can be expected to prolong OS in the limited patients with the UL metastatic who had a favorable response to chemotherapy. Next, I'd like to talk about clinical role of surgery in patients with synchronous liver mets. This figure showed the reported overall survival after the resection of synchronous liver metastasis with a volume of spheres reflecting the number of included patients in each study. The red line shows the linear and progressive improvement of prognosis during the last decades, possibly reflecting the appearance of new and more effective systemic treatments. Median survival time in patients who underwent conversion surgery reached at 34 to 56 months, which is evidently higher than in patients who underwent upfront surgery. This figure showed our clinical experiences of surgical resection for metastatic PDAC, liver metastases. The 37 patients with the resectable, both unresectable PDAC and occult liver metastases were divided into 3 groups. upfront surgery or a short-term neoadjuvant chemotherapy group comprising 7 patients, a conversion surgery after much model treatment comprising 8 patients, and chemotherapy only comprising 22 patients. Median survival time in conversion surgery reached at 48.9 months, which was significantly better than that in upfront surgery or neoadjuvant chemotherapy and chemotherapy group. Even in patients with occult liver mets, conversion surgery after favorable response to a much model treatment may prolong overall survival relative to upfront surgery and chemotherapy alone group. Although progression-free survival in surgery group was significantly higher than that the other groups, most of patients developed the disease recurrences shortly after surgical resection. However, patients in conversion surgery group are good responders to chemotherapy, and post-recurrent chemotherapy can prolong OS in the conversion surgery group. In summary of surgical resection for patients with liver metastasis, a conversion surgery but no upfront surgery can prolong survival. A conversion surgery group has advantages of patient selection, better control of occult metastasis, less extent of surgery due to tumor shrinkage due to the long-term chemotherapy. However, we should recognize the possibility of severe adverse events happen during the long-term chemotherapy, loss of chance for surgical resection, and incidence of postoperative morbidity and mortality in candidates for conversion surgery. The Chinese study group for pancreatic cancer, SPAC, has been conducted in a very interesting and important phase 3 trial for investigating clinical efficacy of conversion surgery in patients with initially liver nodule metastases. The patients with 3 or less number of liver mets, pathological evidence of PDAC, and a PS of 0 to 1 were recruited into this study and received FOLFIRINOX, GNP, or gemcitabine plus S1 regimens. On confirming clinical response of a stable disease or partial response on RECIST criteria, the presence of resectable primary tumor and liver mets, no appearance of new metastatic lesions, and decreased tumor marker levels, they were randomized into operation arm and control arm, consisting of 300 patients. The primary endpoint is overall survival, and the results will appear within a couple of years expectedly. Let's move on to the next topic of atonal dissemination. Patients with atonal dissemination suffer from malignant ascites, abdominal pain, intestinal or urinary obstruction, resulting in dismal prognosis of 6 or 7 weeks in median. There are a few publications in surgical resection of patients with atonal dissemination. Similar to liver mets, a median survival time of upfront surgery was worse than conversion surgery. We have conducted a phase 1-2 study using S1 and intravenous intraperitoneal paclitaxel for patients with occult atonal dissemination diagnosed with the staging lap or open laparotomy, which was not detected on the CT imaging studies. Our phase 2 study showed that a median survival time in 33 patients with atonal dissemination who received S1 plus intravenous intraperitoneal paclitaxel reached at 16.3 months with a partial response in 36%. Surprisingly, conversion surgery was performed in 8 out of 33 patients, 24%, after confirming disappearance of cytology positive and peritoneal nodules. Median survival time of 8 patients who underwent conversion surgery reached at 26 months. The other phase 1-2 study using gemcitabine plus nab-paclitaxel with the intraperitoneal paclitaxel in 46 patients provided a median survival time of 14.5 months and a conversion rate of 17%, which median survival time didn't reach. That was representative data of intraperitoneal paclitaxel regimen. Staging laparoscopy clearly showed the disappearance of peritoneal nodules after intraperitoneal paclitaxel therapy. These patients underwent conversion surgery successfully. Pooled analysis of 79 patients involved in these two trials showed a median survival time of 32.5 months and a conversion rate of 20.3%, but recurrent disease in 75% and long-term survivors in just 3 patients. Thus, even in patients with atonal dissemination who underwent conversion surgery, most of patients had recurrent disease. Subsequent chemotherapy after recurrence can prolong the OS in these patients who were super responders to the chemotherapy. Therefore, CS during multimodal treatment seems to be associated with the prolonged survival, but a further good quality trial will be required for investigating the clinical efficacy of conversion surgery. Now we have been conducting the randomized phase 3 trial for investigating clinical efficacy of S1 plus intravenous intrafetal paclitaxel relative to gemcitabine plus nab-paclitaxel regimen in PDAC patients with atonal dissemination. The results of this study will be appeared in the next 4 years. A clinical practice guideline for pancreatic duct adenocarcinoma with atonal dissemination in Japan stated it is weakly recommended that conversion surgery should be performed in patients whose atonal dissemination becomes undetectable macroscopically and microscopically. Surgical indication for metastatic PDAC varies center to center. For Phenox or gemcitabine plus nab-paclitaxel regimen prolonged the median survival time to 8 or 11 months in patients with metastatic PDAC. Therefore, we should set a desirable outcome of a median survival time in 24 months and a recurrence rate less than 20% in patients who underwent conversion surgery. In this situation, what is an appropriate surgical indication? So strict surgical indication for conversion surgery provides a low resectability but longer median survival time. The presence of clinical response and declined tumor markers seems to be the better parameters for surgical indications. We should establish appropriate surgical indication of conversion surgery for patient safety and prolonged survival. My colleagues in Europe, I'd like to conclude my presentation today. Substantial survival benefits of conversion surgery following favorable response to initial chemotherapy for a certain period of time has been reported. Sustainable efforts are warranted to investigate appropriate regimen for downsizing metastatic PDAC, optimal timing between the initial treatment of surgical resection, and suitable surgical indication. Thank you very much indeed for your kind attention.
Thank you for your outstanding presentation. It was very interesting. And my question, how many maximum chemotherapy course you have prescribed for patient?
Good, thank you very much. So, regimen of so duration of chemotherapy depending on the patient's, performance status. So basically, we have administered chemotherapy at least 8 months after initial treatment for patients with unresectable locally advanced disease and 12 months for unresectable metastatic disease.
Thank you. Please, Professor Gelmut.
Dr. Satoy, very big congratulations to your presentation because you are doing research and doing surgery in an area where there's a lot of controversial, especially with the oncologists. And I feel we need these studies, what you are doing to make progress in pancreatic cancer, because with the increase in efficiency of medical treatment with chemotherapy, also the perspective for the surgeon and for the patient, especially in metastasized pancreatic cancer, is increasing. And I think what you have clearly shown is that in a selected group of patients, it's worthwhile to include also surgery in this concept, because by this survival can be significantly improved and prolonged for the patients. So this is pioneer work. I think you have to fight a lot with your oncologist and have a lot of discussions who are the right patients then and when is the right time point to do the next step, because if he is responding well, they say he's doing so well, now you come with surgery and all these arguments. But I think we have to do this, and we have to provide good data to also to convince the oncologist and the gastroenterologist from these concepts. Congratulations.
Thank you very much, Professor Flies. I totally agree with you. So, we have to make surgery even for the patients with unresectable disease in limitedly. So otherwise we cannot, overcome the, very bad prognosis in patients with the pancreatic duct adenocarcinoma. So we need to explore more sophisticated chemotherapy or local therapy for patients with unresectable disease. Thank you very much indeed.
Thank you very much. We have no questions in the chat, I see, so I would like to close the session. I would like to thank our speakers for the excellent presentations. Thank you for the discussion. Have a nice day, and best greetings to Kiev and Natalia Kubokritz for this wonderful EPC meeting under these horrible circumstances. We are looking forward to travel to Kiev again and to enjoy also the beautiful city and the great hospitality we normally experience when we come to the Ukraine. Thank you.
Thank you very much.
Thank you very much, everyone.
Thank you very much.
So welcome back. I think we can start the next session. My name is Roberto Valente from Umeå University, and I will moderate, I have the honor to moderate this session together with Yuna Cahen from Rotterdam.
Yes, good morning.
Good morning, everybody. So really exciting session, the one that is coming right now. And we have the first speaker, that is Marco Del Chiaro, and we'll talk about surgical treatment of locally advanced pancreatic cancer, vascular resection, and reconstruction. Can we start the video?
Good morning, everyone. Actually, it's not very pleasant to not be in person in Kiev today, but I'm extremely happy to be virtually there with all of you. I want to thank the EPC and the local organized committee for inviting me for this interesting talk. This is my conflict of interest. So many times we say that we didn't do any progress in pancreas cancer treatment, but in fact, we are more and more speaking about treatment of what in the past we didn't treat at all, locally advanced pancreatic cancer. Why? Well, when we check the data, actually, we see that we did something in pancreas cancer treatment. In this paper, we can observe that they increased in percentage in survival from the 70s to around 2010 has been 1,060%. And if we compare with the last data published in literature, of course, in selected population, we see that this increase has been 1,700%. So yes, we did. And what we did actually, we improved our systemic treatment of pancreatic cancer. Pancreas cancer is a systemic disease. We have a better control of the systemic disease. We can probably think to resect more. Now, the problem compared to other kinds of cancer is that even when we analyze the radiological response to neoadjuvant treatment, even with the gold standard treatment, FOLFIRINOX, we realize that the radiological response, especially for what concerns the vascular involvement, happens in a very minority of patients, 20–25%. That's a big problem. So is that patient responder or not? How can we assess if we really need a vascular resection or maybe not, because what we see is just, that tumoral tissue. Well, this is the paradigm of pancreatic cancer today. We know that the standard of care in locally advanced pancreatic cancer is neoadjuvant treatment. We know that only 25% show a radiological response, but from our study in resected patients, we know that about 70% show some kind of pathological response, saying that basically radiology cannot tell us who is a responder, cannot tell us if the tissue we see around the vessel is or not cancer. And that's made even the national NCCN guideline for pancreas cancer change in nomenclature and also changing indication. What was called unresectable cancer is now called locally advanced, but be careful. This definition can be used only before neoadjuvant treatment. At the moment of diagnosis, that means that wherever we give neoadjuvant, this anatomical classification, primary resectable, borderline, locally advanced, is not applicable anymore because we don't really know what we see. Now, what I think expressed very well this new concept is this paper that I've done with one of my fellow analyzing data of the NCDB, including almost 8,000 patients, where we show that T4 is not a prognostic factor for survival in pancreatic cancer. And we propose a new definition of resectability, not based on anatomy, but based on biology. So patient that could have potentially good prognosis, patient that could have, let's say, an intermediate prognosis, and patient with a bad prognosis that probably independently by the local status, independently by anatomy, should maybe not be resected in the future. This is another proof. It's a paper that I did with one of my colleagues years ago, showing that basically whenever you compare borderline resectable or locally advanced pancreatic cancer, even if those require different operation, we don't observe any difference in survival. So again, biology win over technique and over anatomy. The problem we have today is how can we select the best candidate for surgery after neoadjuvant treatment? And when the vascular resection are needed, considering we don't know what we are watching for and what is really technically unresectable. Now, CA19-9 is probably the best predictor factor of response to chemotherapy, but in this study we did a few years ago, we showed that it's true, CA19-9 correlates with survival, but for whatever level of CA19-9, group who underwent surgery go better than the group that doesn't get surgery. Now let's start to discuss a little bit about what we see, what it is, and what technically is considered unresectable. This is a picture that a few years ago, whoever could say is an unresectable tumor. You see here a pre and post neoadjuvant treatment scan, basically similarity, completely disappearance of the superior mesenteric vein, presence only of few branches. Now, if you look carefully, you see that those branches are little, but exist, and we have even a large inferior mesenteric vein. So we went there, we tried to dissect all the root of mesentery. We could identify a branch that is again anastomized with the SMB, and we preserved the AMB. So the biopsy in the root of mesentery were negative. So most of this tissue was not anymore cancer. Another typical case we could call in the past unresectable, central lesion invading basically all the vessel that has been treated with a full divestment of SMA. You see here the aorta, celiac trunk, and a patch resection of the superior mesenteric portal vein. You see here basically the stamp of the pancreas. That was a subtotal distal pancreatectomy. Very, very much similar central tumor of the pancreas, what we would call in the past unresectable, has been done doing a vein anastomosis. You see here end-to-end SMB portal vein, but that didn't require any arterial resection. Has been treated with divestment because the tissue came out around the vessel very nicely. So again, another proof that chemotherapy and radiology after chemotherapy that cannot predict when those kind of big arterial resection should be performed. Very similar example in this case, I mean, there is a full replacement of the hepatic artery from SMA, divestment of the artery, vein resection with direct anastomosis. In other case, very similar picture to before, we couldn't. And then, yes, we did a vein resection, but we did even arterial resection. You see here the hepatic artery with a direct anastomosis on the celiac trunk. So same picture, but different outcome, different need for surgical resection, which is unpredictable before surgery. This is another case, even more extreme, of a central tumor invading both SMB and SMA that has been treated with a total pancreatectomy and resection both of the superior mesenteric vein and superior mesenteric artery with the direct end-to-end anastomosis. So basically auto bowel transplantation. Now, how those operation goes, you know, there are several series, very encouraging results, but I put here only the data coming from probably the largest series existing in literature, which is the series of Heidelberg, including around the 400 cases of locally advanced pancreatic cancer. Just by note that they start to collect patients from 2003, so very far when we didn't have efficient chemotherapy like today. Still, we have a decent median survival in those patients. Obviously, those operations, either if you use divestment or you use arterial resection, they're associated with a significant mortality rates, but still, I mean, definitely not prohibitive mortality rates. In conclusion, pancreatic cancer is a systemic disease. With improvement of systemic control, there is less impact of local status in survival. Radiology after neoadjuvant treatment is not a completely trustable tool to assess prognosis and technical feasibility. Preoperative imaging predict quite well the need for a vein resection, but no for arterial resection. So whenever you go there, you need to be ready to do divestment or an arterial resection is needed, and you cannot really predict before. Selection for surgery should be based on biology and not on anatomical detail. An aggressive operation can be worth for a very good biology tumor, as well as maybe a primary resectable should not be resected if the biology is not good. Surgery for locally advanced pancreas cancer can be done with acceptable morbidity and mortality and comparable long-term results to normal pancreatectomy, but where? And this is a new concept. This is something I had the honor to be part of, was a position paper of the Japanese Society of Hepatobiliary Pancreatic Surgery, where basically the question was, is it enough to be a high volume center in pancreatic surgery to really afford this kind of operation, or super specialized center? Expert in this kind of operation should be identified in the future. I don't have yet an answer, but I think this is a very intriguing question. And saying that, I really want to thank you very much for this kind of invitation.
Thank you very much, Marco, for this terrific lecture and the beautiful picture you have shown to us. I don't know whether there are questions from the audience. There is one from Guralp asking, when do you decide to add radiotherapy as a neoadjuvant treatment, especially when arteries are involved? That's a very nice question.
Well, first of all, it's emotional to see all of you, even if virtually, and really it's pity that we cannot see each other in person. It's a great question, and I have a personal answer. I don't have a very basic, evidence-based answer. I generally ever used, or at least very rarely use a radiation when an artery is involved, because I'm afraid about potential damage on the arterial wall by radiation. I think I'm even more convinced now after the results of the Alliance trial that basically not only failed to show superiority of radiation, but actually was closed before the end for inferiority of the arm using radiation in combination with FOLFIRINOX versus FOLFIRINOX alone. I don't think a single prospective randomized trial closed the match. So I think there is still room for discussion. Personally, I try to avoid to give radiation to patients that potentially could need a divestment or an arterial resection.
Thank you. Then we move to the second question, which is, should total pancreatectomy rather than pancreatic adenoectomy be done in cases of arterial resection to prevent leakage and pseudoaneurysm?
In general is what I do. Even there is no evidence, and it's very true when people say generally those patients have very hard pancreas, so the risk is little. I agree, that's probably true. I'm generally using to do that, and I have to say that the splenic artery or rotational splenic artery is an amazing conduit for reconstruction of arteries. So you give two events. One, you reduce maybe the risk. The other one, you have available a graft that needs only one anastomosis. But again, I don't think this should be the rule. It's generally what I do is very debatable.
Thank you very much. And then a question about the role of radiomics in pancreatic cancer.
Yeah. Well, I'm not a radiologist, so probably I'm not the right person to answer. I think this question is probably means that is it possible with radiomics to understand the response to chemotherapy? I don't know, hopefully. I think we need a better biomarker. Probably at the end, we need a score that measure the possible response, biological, radiological, and don't forget in this situation, the patient characteristics, which are anatomic, example, obese versus non-obese versus, comorbidity versus no comorbidity, versus patient preference. And I think we need to be honest and clear when we explain this operation to patient, expectation, possible consequence, and sequelae. More than complication, which I think today we can keep pretty low. I believe low for pancreatic surgery, obviously. I believe a consequence. I think, for example, chronic diarrhea. I think, for example, brittle diabetes. So all these things need to be put together, discussed with the patient, and then if the patient is on board, and there is a biological rationale, I don't think anatomy should stop. I think biology should stop surgery, not anatomy.
Thank you very much. And then I have one provocative question, but Marco, I do that as an outsider because I'm a gastroenterologist. And the question is, why in some centers we do an arterial resection for a tumor which is located in the distal, in the distal pancreas, whether it is not done or not always is done when there is an involvement of the hepatic artery. Is there something that goes beyond, is something that I'm missing? What do you think?
I'm not surprised that you being outsider, you make this question, because surgeons are biased and the gastroenterologists or oncology are not biased because they don't do the operation. So what I'm saying is that has been something that I agree. I mean, we now go in the direction to do neoadjuvant to everyone, I think. At least this is my personal philosophy, even in primary resectable, because again, biology, that helps us to select the best candidate for surgery. But the reality has been in the past, we had a huge tumor in the body and tail. We did a resection. There was infiltration of splenic artery, splenic vein. No one was caring about that because it's easy. And that's exactly the point. So I think, I mean, anatomy is fine because that's increase the risk. So if you have a patient, of course, with comorbidity, one thing is to do a distal, one thing is to do a Whipple with vascular resection, obviously. But again, that's a technical issue as a risk assessment issue, but it's not a biological issue. So I believe, you know, I challenge people to give me another example of a cancer where we classify resectability based on how many degrees there is a contact with the vessel. Is 178 or is 180? Is 85 or is 90? Only in pancreas. The only reason is technical, because I mean, why pancreas should be different from all the other cancers where we don't have this kind of classification in deciding for resectability. And again, this is a personal opinion, but I think we should reflect on that. And the things that you saw it is because you see from, let's say, a unbiased perspective, which is not the one to scrub and go in the OR. So I think we need to focus more as a surgeon on biology, which probably means reducing even our operation, probably doing even less primary resectable. Because that's not the issue. The issue is, has the patient an advantage to get surgery or it doesn't have any advantage? If it doesn't, we should not do surgery. Vice versa, if he has, probably we need to push in those cases, even our indication. And again, this is a personal opinion, and I'm completely okay with any disagreement because, you know, it's just an opinion.
Thank you very much. So we can summarize that biology matters and probably even the surgery, of course. So
Thank you.
We move forward.
Yeah, thank you, Marco, for always inspiring us. It's my honor and pleasure to announce our colleague from Japan, Professor Kiyoshi Takaori, who will talk about familial pancreatic cancer. I'm looking forward to it. Thank you.
Thank you very much for the kind introduction. Thank you, EPC. Please start my video. Ladies and gentlemen, today I'd like to talk about familial pancreatic cancer. I have nothing to disclose. As we all know, pancreatic cancer is a highly lethal disease. In 2021, about 500,000 people were diagnosed as having pancreatic cancer, and the vast majority of them have died of pancreatic cancer. If you look at the lifetime risk of developing cancers, the incidence of pancreatic cancer, lifetime risk of pancreatic cancer is quite low, 2.0% for female and 1.15% for female. Although the incidence of stomach cancer is relatively high in Japan, the incidence of other cancers are similar between Europe and Japan. Therefore, there are challenges in early diagnosis of pancreatic cancer. Number one, pancreatic cancer is extremely highly lethal disease. Number two, the incidence of pancreatic cancer is relatively low, making it difficult to justify cost-effectiveness of screening of pancreatic cancer. Thus, we have to look for the risk factors of pancreatic cancer. The well-known risk factors of pancreatic cancer include smoking, diabetes, obesity. But most importantly, hereditary cancer syndrome and family history of pancreatic cancer are significant risk factors of pancreatic cancer. The definitions of pancreatic cancer candidates are those having at least 2 first-degree relatives affected with pancreatic cancer. When we search the large cohort study, the rate of familial pancreatic cancer among patients with pancreatic cancer was 4 to 10%. Therefore, familial pancreatic cancer is no longer rare disease. In 1994, the National Familial Pancreatic Tumor Registry was established at Johns Hopkins. In Europe also, Europac and FAPACA were established in 1999. Dr. Kant has conducted screening of familial pancreatic cancer kindred and Poitiers syndrome patients. During a follow-up period of about 5 years, they have identified positive imaging for pancreatic regions in 22% of patients and histological proven pancreatic neoplasms in 10% of patients. And they have resected the pancreatic specimen in 7 patients and found IPMN with carcinoma in situ, IPMN with microinvasive carcinoma, or IPMN with panning, mostly low to middle grade. Unfortunately, however, we didn't have familial pancreatic cancer registry in Japan until 2012, where we have conducted kickoff meeting for the registry. With the aid of Dr. Ralf and other colleagues, we have launched Japanese Familial Pancreatic Cancer Registry in 2013. And we have established JFPCR institutions throughout the country, like this one. And through the website for the patient and their families, we have so far recruited 500 individuals. The inclusion criteria were pathological proven pancreatic cancer patient and their kindreds, and hereditary cancer syndrome associated with pancreatic cancer. Those individuals visit JFPCR institutions, and they do a questionnaire and register those patients through a unique online registration system where we can collect all the anonymous data from the patient. And the center at Kyoto University can issue a printer for the follow-up survey, and those prints go to each JFPCR institution, and they can do a follow-up survey using these letters. We also conduct collateral research projects such as screening program with EUS MRI in familial pancreatic cancer kindreds, next generation genome sequence, chemotherapy, prophylaxis of pancreatic cancer development in familial pancreatic cancer kindreds using vaccines and chemical agents. This is another recent study by Dr. Kanto, and they concluded that the survival of those patients with pancreatic cancer detected during surveillance was superior to that without surveillance. And according to literature, the resectability of those patients detected during surveillance was 100%, 70%, 33%, and so on. And according to meta-analysis of 16 sheets of surveillance, including 5 studies with control groups, the resectability in family high-risk groups was 60%, while it was only 25% in control groups without surveillance. So we started Diamond study, which is surveillance study for kindreds with familial pancreatic cancer and individuals with hereditary pancreatic cancer syndrome. The endpoint was the fraction of patients with resectable pancreatic cancer among the total number of patients with pancreatic cancer found through surveillance interventions. This is a typical schema of this study. If the resectability is improved from 20% to 80%, we can conclude that the screening is efficient in these high-risk groups. According to CAPS the individuals suitable for screenings are considered those with 5 times higher risk of pancreatic cancer and or lifetime risk of pancreatic cancer greater than 5%. This would indicate that family pancreatic cancer kindreds, Poitz-Ingham syndrome, one or more affected first-degree relatives plus mutations may be good candidates. This is the exact criteria of Diamond study. In the interest of time, I don't tell you all the details, but this is similar to the consensus of CAPS. Then we classify those individuals into three groups. Number one, pancreatic malignant regions in need of treatment. Number two, pancreatic regions that can be followed up. And number three, normal pancreas. Those patients with pancreatic regions that can be followed up and those individuals with normal pancreas will undergo surveillance every 6 months. And the MRCP and EUS will be carried out alternatively, and blood tests and medical check-up will be done every time. And during the surveillance of 15 years, we will collect those cases who developed pancreatic cancer and check if they are unresectable or resectable. And this would be the primary endpoint of our study. And we also evaluate the difference between the initially identified pancreatic malignant regions and those pancreatic cancer detected during the surveillance. This will be the second endpoint. Now, in the previous studies of biomarkers, the existing markers were established by comparing the patients and the healthy volunteer. But in Collateral project of biomarkers for the FPCR, we can collect those samples while the patient developed the pancreatic cancer through the cascade of panning regions. In this way, we are trying to develop novel markers for early diagnosis. We also conducted a public study, which is a study on chemotherapy with gemcitabine plus oxaliplatin in those individuals with family history and some with mutation BRCA, HER2, and so on. In summary, Japanese Familial Pancreatic Cancer Registry was established in 2013. We are conducting and planning collateral studies of the FPCR, including the ongoing Diamond study. We plan to have further collaborations with CAPS. In conclusion, Familial Pancreatic Cancer Registry will play a pivotal role in the screening program, development of early detection markers, and novel treatments based on the individual genetics. Before ending my talk, I would like to invite you all to the Joint Congress of International Association of Pancreatology and Japan Pancreas Society. There will be a special lecture by Professor Natalia Gubergoris and a session of JPS meets EPC along with Professor Matthew Thrower and Professor Heiko Witt. Please join us in Kyoto. Thank you very much for your kind attention. Thank you very much.
Start my video. Maybe the technical department can enable the video to start.
Yeah.
Yes, thank you.
Yeah, I can see your picture. Oh, yeah, there you are.
Yes, yep. Thank you so much. Very interesting and amazing work. I didn't see any questions from the chat. I have a question for you. We have recently published our results from our cohort of almost 400 familial individuals with an increased hereditary risk for pancreatic cancer. And we found it very intriguing that we didn't find any malignancies after 5 years in the familial pancreatic cancer group, and only in the genetic, the mutation carriers. And from a concept view, it's difficult to explain those results, but they were quite obvious that the risk in familial pancreatic cancer patients does not seem to be elevated. And I was wondering what your thoughts are on this finding.
Yeah, that's a very important point, that the genetic mutation is more important. And actually, we have studied on the effect of the platinum chemotherapy on those patients with genetic alteration and those patients of familial pancreatic cancer. And we couldn't find any significant benefit in those patients with just family history of pancreatic cancer. But we did see the difference in those patients with genetic alteration. So I think what you mentioned is a reflection of this phenomenon. But we still think that there are so many genetic alterations which we were not identified yet. So that's why we are conducting this study of familial pancreatic cancer registry. And actually, I'm a surgeon, and this is another way to increase the resectability. I was very much impressed by super technical Professor Del Chiaro, but in this way also we can increase the resectability. That is my point.
Thank you. Thank you. Roberto, maybe you can introduce the next speaker.
Yes, thank you very much. It's my honor to introduce the next speakers. That is Dr. Julio Iglesias Garcia, and he will talk about the usefulness of endoscopic ultrasound guided elastography for the diagnosis of malignant of solid pancreatic tumors. He will show an analysis of a large prospective registry from a referral center.
Well, first of all, I would like to thank the EPC for the opportunity to give the result of our study on the usefulness of AUS-guided elastography for the diagnosis of malignancy of solid pancreatic lesions. And this is the analysis from a large prospective registry from a referral center. These are my personal data. And these my financial disclosures regarding this study. So one of the main topics when we manage pancreatic diseases is the differential diagnosis of solid pancreatic tumors. And we know that this is a problem because we have not only benign diseases, but mostly malignant diseases. And it's very important to differentiate in order to establish the best treatment for our patients. So of course, the best tool in the differential diagnosis of solid pancreatic tumors is AUS-guided sampling. We know that it's accurate both for malignancy and also for determining the benign origin of our lesions, and this accuracy is estimated to be over 90%. But this 90% means that we still have some false positive and false negative results. And another of the potential problems of AUS-guided sampling, although we know it's low numbers, is the possibility to have adverse events that in some occasions it can preclude surgery. So the question is, do we have any additional tools that may help in determining the malignant potential of our solid pancreatic tumors? And I think the answer today is yes. And one of these tools, AUS-guided elastography. We know that this technique, strain elastography, is going to evaluate the relative stiffness of the tissue by its response to compression. And we can have some qualitative patterns, but also some quantitative evaluation. If we focus in qualitative patterns, we know that when we have soft lesions that are going to be translated into green patterns, this is quite accurate, as we will see. And when we have blue hard lesions, this is mostly related to malignant lesions. So with this evaluation, we know that the accuracy of AUS-guided elastography to evaluate the differential diagnosis of solid pancreatic tumors provides very high sensitivity, ranging from 80 to 100%, but with low levels of specificity, as we've learned from the literature. And this specificity is mostly related to some benign lesions, that neuroendocrine tumors that sometimes are difficult to determine whether they can be malignant or benign, but mostly in the evaluation of mass-forming chronic pancreatitis in the setting of calcific chronic pancreatitis. As of course, there is another potential complication of AUS-guided elastography for increasing the accuracy, and is the need for a learning curve. So the experience is also a lot to do with these levels of accuracy. So with this background, the aim of our study was to evaluate the accuracy of AUS-guided elastography for the diagnosis of malignancy of solid pancreatic tumors in clinical practice in a tertiary referral hospital. So we designed a study with an analysis of a prospective AUS registry at the University Hospital of Santiago de Compostela in Spain. And we include those patients who underwent an AUS with AUS-guided elastography for the evaluation of solid pancreatic tumors between 2009 and 2020, in patients that have a definitive histological diagnosis of the disease, mostly based on AUS-guided biopsy and or the surgical specimen. The study was performed with the linear pentax echondroscopes attached to the Hitachi systems. And for the elastographic evaluation, we considered blue predominant patterns, hard lesions, to be malignant, whereas green predominant patterns related to soft lesions were considered to be benign. These are an example of some of the lesions included in the study. So we can see the typical blue pattern corresponding to malignant tumors. In this case, were 2 cases of pancreatic adenocarcinoma. And in these other images, we can see 2 benign lesions. This is in a result of a chronic pancreatitis, and this is a G1 benign neuroendocrine tumor. And we can see in these 2 cases the complexity of evaluating by elastography mass-forming chronic pancreatitis in the setting of calcific chronic pancreatitis, which is very important to make the evaluation in the areas without calcifications. And for instance, in this case, it turned to be a small foci of pancreatic adenocarcinoma in the setting of a calcific chronic pancreatitis. So for the statistical analysis, data will be shown as mean and standard deviation, and we evaluated the diagnostic accuracy by the calculation of sensitivity, specificity, positive predictive value, negative predictive value, and overall accuracy. These are the results. We finally included 864 patients with a mean age of 67.7 years. Most of them were males. Mean size of our pancreatic lesions were 34 millimeters, and the lesion location, most of our cases, close to 60% were located in pancreatic head, 30% in pancreatic body, 7% in pancreatic tail, and 3% of our lesions were located in insulin process. Final result of our cohort of lesion were 86% of malignant lesions. Of course, most of these lesions were pancreatic adenocarcinoma, but was not the only diagnosis in pancreatic malignancy. And close to 40% of our lesions tend to be a benign lesion. But let me just focus on the result of the 200 lesions that were not pancreatic adenocarcinoma, mix of benign and malignant lesions. In malignant, look, 43 patients tend to be a malignant neuroendocrine tumor, 36% patients presented pancreatic metastasis, and 9 patients presented other type of malignant lesions like pancreatic lymphoma. And in the cohort of benign cases, 87% presented a mass-forming chronic pancreatitis, and 26 cases were a benign neuroendocrine tumor. So when we take a look at the diagnostic accuracy of AUS-guided elastography, it turned out that our sensitivity was 98.5% with a specificity of 86.8%, with both positive and negative predictive value over 90%, with a very, very good overall accuracy over 95%. So our final conclusion is that AUS-guided elastography is a very accurate tool for the evaluation of solid pancreatic tumors, allowing the confirmation or exclusion of malignancy with a very high accuracy. So thank you very much for the attention, and open for the Q&A. Thank you.
Thank you very much for this excellent lecture. Is there any question? Okay, I don't see questions directly from the audience. No, yes, there is one. It says the WHO classification does not longer distinguish between benign and malignant neuroendocrine tumors. Which criteria were used?
Well, first of all, hello. Well, just to answer this question, what we used to differentiate between benign and malignant, it was mostly based on the histological analysis. So when we have G1, that means the levels of Ki-67, the proliferation index, and also the number of mitosis. So when these levels were low, those were considered below 2 centimeters to be benign neuroendocrine tumors, and those G3 with high proliferation index and high number of mitosis, those were classified as malignant. So this is how we try to differentiate, because the management of these two types of tumors is completely different in the management of NETs today.
Thank you very much. Another question is, what about the use of artificial intelligence algorithms? Is there any rooms for that?
Well, I know it's Gabriele making this question. It's a very nice point, because there starts to be some data on how to make a mix between elasto and artificial intelligence. In fact, we have been part of a study that was conducted by Adrian Saftoiu from Romania, with showing that when we give these images to a computer, the accuracy, it remains mostly the same as with the human eye. But I think there is a field to improve and to give to the machine to try to avoid any kind of bias when you're trying to evaluate. Although I think it's a little bit tricky, because if you remember the image of the calcific chronic pancreatitis, sometimes you need to understand what you're seeing. So sometimes you need to see this small blue foci in the setting of a huge chronic calcific pancreatitis with a lot of calcifications that are always going to be blue. So it is a little bit tricky, but I think there is a field for the artificial intelligence to make to improve the accuracy, not only from elasto, but also from B mode. So there is some very nice things that will come in the future on AI associated to AUS and also in the field of elasto. So it's a very good question. Probably Gabriele knows more about what is going to happen in the future, because I'm sure that Paolo is bringing him some nice information.
Thank you very much. Okay, I think that we can go ahead.
Yes.
Thank you.
Our next speaker from Japan again will talk about the indications for surgery and outcomes for conversion surgery for initially unresectable locally advanced pancreatic cancer. The floor is yours.
Thank you, Chairman, for giving me a great opportunity to present our data. I would like to talk about surgical indication and outcomes of conversion surgery for initially unresectable locally advanced pancreatic cancer. My name is Yuta Yoshida. I'm from Department of Surgery in the University Hospital in Japan. We have nothing to disclose. As you know, treatment of pancreatic cancer is performed according to the NCCN guidelines, resectability status. They propose that the decision about resectability status should be in consensus at multidisciplinary meetings and discussion. In 2016, Japan Pancreas Society introduced the resectability status, which is similar to the NCC guidelines. In the Japanese classification of pancreatic carcinoma, 7th edition. This is a treatment algorithm of Japanese clinical practice guidelines for pancreatic cancer 2019. Clinical stage 3, pancreatic cancer, URLA, pancreatic cancer patients should be treated with radiotherapy and chemotherapy. With recent advances and improvement of chemotherapy and/or chemoradiotherapy, reports of conversion surgery for initially unresectable pancreatic cancer have been increasing. The purpose of this study is to evaluate the surgical outcomes in patients who underwent conversion surgery for initially unresectable locally advanced pancreatic cancer. We retrospectively analyzed the data of consecutive 93 patients with URLA pancreatic cancer in our hospital between 2014 and 2022. Of these, 31 patients underwent conversion surgery and 62 patients did not. Study endpoints include short and long-term results of conversion surgery group, patients' characteristics, and preoperative treatment prognostic factors and risk factors of recurrence after convolutional surgery. This is our surgical indication, diagnosis, treatment, and surgical indication for all URL-PC are evaluated in a weekly multidisciplinary conference. Regarding to surgical indication of convolutional surgery, although the definitive indication is not established, we carefully review the following point in each patient. Anatomically resectable on CT scan. Disease control at least 3 to 6 months. Decreased tumor marker level. Decreased over negative for FDG uptake on PET-CT. Maintenance of performance status and nutritional status. This is patient's characteristic before initial treatment. We performed convolutional surgery to 31 patients. Thus, its resectability is 33.3%. About ages, sex, tumor region, diameter, tumor, major vessel invasion, there were no significant difference between two groups. However, CA99 and DUPAN-2 levels were significantly lower in the convolutional surgery group. This slide shows regimens for URL-PC. Gemcitabine plus nab-paclitaxel cell therapy was most performed of 68% and 65% as first-line chemotherapy in convolutional surgery and non-convolutional surgery groups, respectively. 60 patients, which is 57%, underwent chemoradiotherapy. This slide shows each regimen for 31 cases undergoing convolutional surgery. Median time from initial treatment to convolutional surgery is 8 months. GNP therapy was most performed as first-line chemotherapy. In addition, chemoradiotherapy before convolutional surgery was performed in most recent cases. This is surgical outcomes and pathological findings. SSPPD was performed 14 patients, TP-CAR in 13, TP in 3, TP 1. 5 patients presented lymph node metastasis. R0 resection rate was 83.9%. Surgical mortality was 0. Overall morbidity rate defined by CD classification more than grade 3 was 60%. This is overall survival after initial treatment of all URL-PC. MST was 19 months. Overall survival was significantly better in the convolutional surgery group compared with the non-convolutional surgery group. In the convolutional surgery group, median survival time was 41 months, and 1, 2, and 3 years survival rate were 89%, 73%, and 59%, respectively. This table shows prognostic factor for URL-PC. On multivariate analysis, DUPAN-2 levels before initial treatment, prognostic neutral index, and CS were identified as prognostic factor in patients with URL-PC. This is disease-free survival after convolutional surgery. 70 patients developed recurrence. Of these 6 patients, developed early recurrence within 6 months after conversion surgery. This table shows risk factors of recurrence after conversion surgery. On multivariate analysis, blood loss, vascular resection, and PT factor were identified as risk factor of recurrence after conversion surgery. In summary, long-term outcomes of conversion surgery was favorable. Short-term outcome of conversion surgery was acceptable. P and I returned to levels before initial treatment and conversion surgery were identified as prognostic factor in patients with URLPC. Blood loss, vascular resection, and PT factor were identified as risk factor of recurrence after conversion surgery. Conclusion: CS for URLPC may be useful for survival with an acceptable risk of surgery in selected patients. Further study will be needed to evaluate the efficacy and selection of the patients who will really have benefit is conversion surgery. Thank you.
Thank you so much for presenting your work here. So far, I don't see any questions in the chats. Are you now planning a randomized trial to evaluate the effects?
Now I don't plan the evaluation of this factor and performance factor.
Because it's super interesting, but of course, being a retrospective study, the bias is so obvious that it makes you very curious how a prospective study would do.
Yes, thank you.
Humberto has some questions as well, I think.
Yes.
Oh no, Gulab has questions.
Yes.
Gulab Sayan asks you, how do you define unresectability?
Unresectability. Surgical indication is slide in this slide. Unresectability we evaluate on CT scan.
On a CT scan.
Yeah.
Yes. And then Gulab also asks you, why did the conversion group receive highly significantly radiation therapy? Can this have affected your results significantly since both groups were not treated in the same way?
We think the effect is of chemotherapy is favorable, and so the chemotherapy achieved the R0 resection rate.
So I think, again, the obvious solution would be to randomize and to treat both arms in the same fashion and then see what results come out of that. But your study is encouraging that this is definitely a field that we should further explore, which is, of course, what's happening now. I don't see any more questions. Roberto, can you introduce us the next speaker?
Yes, thank you very much. We move forward. The next speaker is Daisuke Hashimoto, and he will talk about the strategy of neoadjuvant therapy for resectable, borderline resectable pancreatic ductal adenocarcinoma.
Can you hear me?
Yes.
Okay. So thank you, Chairman. I'm Daisuke Hashimoto from Kansai Medical University, Japan. So please start my video. I'm Daisuke Hashimoto from Kansai Medical University, Japan. I am very honored to present our study in APC 2022. I'll talk about strategy of neoadjuvant therapy for R and BR PDAC. I have no COI. Advantage of neoadjuvant therapy for resectable and borderline resectable PDAC has been described in recent clinical trials. In Japan, a multicenter randomized phase 2 and 3 trials for R and BR PDAC, PrEP2, showed a significant advantage in overall survival of neoadjuvant therapy with gemcitabine and S1 compared to upfront surgery. MST was 37 months in test arm and 27 months in control arm. In addition, as you know, PREOPANC trial from Netherlands showed a significant advantage in long-term overall survival of neoadjuvant chemoradiotherapy compared to upfront surgery. MST was 16 months in NAC-CRT group and 14 months in upfront surgery. Based on these evidences, clinical practice guidelines from Japan Pancreatic Society recommends neoadjuvant therapy for both R and BR PDAC, but not upfront surgery. Especially, gemcitabine plus S1 therapy is recommended for resectable tumor. However, evaluation method of the effect of neoadjuvant therapy and the best timing of surgery after neoadjuvant therapy has been still controversial. In other words, we don't know how to make a surgical decision. Can we perform the surgery as long as we complete the planned regimen, or based on radiological findings, or small marker response? The aim of this study to investigate overall survival and prognostic factor of surgical resection following neoadjuvant therapy in patients with R and BR PDAC. This was a single-center retrospective study in our institution. In total of 150 patients with R and BR PDAC who underwent neoadjuvant therapy from 2002 to 2020 were included. Upfront surgery and patients who underwent conversion surgery for initially diagnosed locally advanced or metastatic PDAC were excluded. This is a baseline characteristic of the study cohort. 66% had R and 34% had BR PDAC. Tumors were located in pancreatic head in 64% and pancreatic body and tail in 36%. The regimen of neoadjuvant therapy was gemcitabine and S1 in 71%, gemcitabine plus nab-paclitaxel in 30%, and so on. 9% received multiple lines of chemotherapy. Overall survival of the total study cohort was 39 months from the induction of neoadjuvant therapy. The resection rate was 95% and median overall survival of the resected patient was 43 months. Reason of abandoning surgery was appearance of distant metastasis in 7 patients and severe adverse effect of chemotherapy in 1 patient. When stratified with resectability of the primary lesion, there was no significant differences in overall and disease-free survival. In other words, we think that Better survival was archived in BR-PDAC, similar to R-PDAC. In resected group, patients with lymph node metastasis showed significantly worse overall survival. MSD was 61 months in N0 patient and 36 months in N1 disease. In addition, patients who did not receive adjuvant chemotherapy showed significant worse survival compared to patients who received it. 10 months versus 46 months. Next, we analyze whether the decrease in CA19-9 caused by neoadjuvant therapy contribute to postoperative survival. If the cutoff of preoperative CA19-9 was set to 200, there was no significant difference in overall survival. However, the cutoff was set to 37, it means normal level. Overall survival of patients with CA19-9 37 or less, 69 months, was significantly better than those with 37 or more, 35 months. Moreover, we focused on the reduction rate of CA19-9 during neoadjuvant chemotherapy. Overall survival of patients with a reduction rate 50% or more, as 62 months, was better than those with less than 50%, 38 months. However, the difference was not significant. Overall survival of patients with the reduction rate 70% or more, as 84 months, was significantly better than those with less than 70%, 36 months. Based on these findings, univariate and multivariate analysis for overall survival was performed. Preoperative CA19-9, reduction rate of CA19-9, lymph node metastasis, and induction of adjuvant chemotherapy were independent prognostic factors. In addition, reduction rate of CA19-9 and lymph node metastasis were independent prognostic factors for disease-free survival. CA19-9 response during neoadjuvant therapy has been noted as prognostic factor in recent studies. Leo indicated that reduction rate of CA19-9 less than 50% was significantly associated with worse survival. And Yamada also showed the recovery of CA19-9 was a preferable prognostic factors in patients with PDAC who had undergone adjuvant therapy. This is our conclusion of the presented study. Thank you for your attention.
Thank you very much for this excellent lecture. We have a question from the audience, and how do you decide which neoadjuvant regimen to take for individual patient? You have presented 4 different possibilities.
Yes, thank you for the question. I'm sorry, I can't show my face. All right. So basically, we treat the resectable PDAC patient with the gemcitabine plus S1 combined therapy. And for BR-PDAC, we choose the gemcitabine plus nab-paclitaxel.
Okay.
Is it okay?
Yes, thanks. Is there any other question? Okay, I have one question. I think that it was very interesting results. And first of all, I mean, I think it's very important to see to show the importance of CA19-9 and the dynamic of it during the course of chemotherapy. My question is, which percentage of your patients did not express the CA19-9? Because we know that this is a marker that not all pancreatic cancer patients express. I mean, there is a part of the population which might not have increased the CA19-9 despite the pancreatic cancer.
So your question is about the non-secretor of CA19-9?
Yes. Which your population did not.
Yes, it is very big program in recent days. So now we check the CA19-9 with DuPont-2 in at the initial treatment before the start the NAC treatment. So we check the both marker CA19-9 and DuPont-2.
Okay, but which was the percentage of patients who didn't have any?
Maybe 10 or 20%.
Okay. Okay, that is of course a limitation. Thank you very much.
Thank you.
I think we move forward because we are quite late. So please, Dina.
Yes. It's my pleasure to introduce Anna Caterina Milanetto. Hello, Anna, nice to see you. We will talk about the results of enucleation of insulinomas, the surgical treatment in her center in Padova.
Good morning to everybody. I will talk about our 43 years experience of open enucleation of pancreatic insulinomas of our surgical center in Padova in Italy. So insulinoma is the most frequent functioning pancreatic neuroendocrine neoplasm. And in 99% of cases, it is located in the pancreas. And in 90% of cases, it is single. And in 95% of cases, it is benign and sporadic. So in the other cases, it can be associated to MEN1 syndrome and therefore a multiple. Insulinoma is a tumor of surgical interest because almost all patients can be cured with surgery. Whenever possible, a parenchyma sparing procedure should be performed to prevent early and late onset of diabetes and exocrine insufficiency. Therefore, enucleation is strongly recommended, also because it gives to the patients an excellent quality of life. What about literature and the recommended surgical approaches for neuroendocrine neoplasms? As you can see from this flowchart, for insulinomas, a parenchyma sparing resection is recommended, and also for asymptomatic non-functioning NETs less than 2 centimeters in size. But for non-functioning NETs more than 2 centimeters in size, a standard pancreatectomy should be performed. And there are a lot of parenchyma sparing procedures. So if the insulinoma is located in the head of the pancreas, we can perform a duodenum preserving pancreatic head resection. Then a central pancreatectomy should be performed for an insulinoma of the neck of the pancreas. And a spleen preserving distal pancreatectomy can be chosen for an insulinoma of the body tail region of the pancreas. And then we can also perform an enucleation. That is the matter of our study. Minimally invasive pancreatic surgery has a lot of advantages, but also, unfortunately, some disadvantages, mainly when dealing with insulinomas. And first, it gives us a decreased haptic feedback, so that regarding enucleation, the precise localization of the tumor may be challenging. And what we need is an appropriate preoperative imaging, because this is the key for localization. And when we see the reported studies in the literature regarding laparoscopic approach for enucleation of insulinomas, there's a reported conversion rate from laparoscopic to open approach from 4.5% to 27%. And the main reason for conversion is a non-localization of the tumor. And this is a systematic review of open versus minimally invasive enucleation for all pancreatic neuroendocrine neoplasms. As you can see, they collected more than 600 patients who underwent an open approach and more than 300 patients who underwent a minimally invasive approach. And what can we see is the reported fistula rate. So we have at least 20 to 26% of fistula rate. Of course, we are talking about clinically relevant fistula, but in the single series, it can be up to 47%. And then we also can observe recurrence rate that is almost 8% with the minimal invasive approach, and this is doubled than the rate that we can observe in the open approach. So in our study, we included patients who underwent an open enucleation for insulinoma in our pancreatic and digestive endocrine surgical unit in Padova from 1979 to 2021. So this is a retrospective study covering a period of 43 years. And we evaluated short-term outcomes such as morbidity, so mainly pancreatic fistula and post-pancreatectomy hemorrhage, and mortality. And then also long-term outcomes as pancreatic endocrine function and recurrence and survival. So among 88 pancreatic operations performed for an insulinoma, 48% were enucleations, and we enrolled 42 patients. We decided to exclude MEN1 patients because of multiple tumors, so multiple enucleations or other approaches, and 29 of them were women with a median age of 56 years up to 83 years. And all of them presented with symptoms related to an organic hyperinsulinism. These are the results regarding histology. As you can see, median tumor size was 1.3 centimeter. So 93% of tumors were stage 1, and only 3 insulinomas were more than 2 centimeters in size. And they were mainly located in the head or uncinate process of the pancreas. As you can see here, almost 70% of them were there. And most of them, 84%, were grade 1 tumors, and only 5 insulinomas were grade 2. These are the early postoperative outcomes. As you can see, 31 patients, so 73% had an uneventful postoperative course, and median hospital stay was differentiated between the first 2 decades of our study, when it was almost 14 days, and now in the last 20 years, we reached median hospital stay of 10 days. We had only 1 reoperation for an early incisional hernia, and mortality was nil. These are the surgical postoperative complications, and as you can see, post-pancreatectomy hemorrhage occurred only in 1 patient treated by a blood transfusion, and there were no delayed gastric emptying reported, and there was a 12% rate of biochemical leaks, so the former pancreatic fistula grade 1. And regarding clinically relevant fistulas, we had only a fistula rate of 9.5%, and there were only fistula grade B, so only in 4 patients. We did not observe grade C fistulas. And I reported here on the right side the results from a systematic review regarding limited surgery for benign tumors of the pancreas. And as you can see, when performing the enucleation, one can have clinically relevant fistula rate of around 16%. So one of the tools that we used since 1985 is intraoperative ultrasound, and it is very useful to assess the distance between the tumor and the main pancreatic duct. After a mean follow-up time of more than 17 years, 32 patients, so 76% are alive with no evidence of disease. We observed no disease recurrence at all, and only 3 patients, so 7%, developed new onset late diabetes. So in conclusion, enucleation in open pancreatic surgery was performed in nearly half of patients for the treatment of insulinoma. And in our experience, enucleation provided as a short-term outcome a low rate, so less than 10% of grade B pancreatic fistula and no perioperative mortality. And as a long-term outcome, we had an excellent preservation of endocrine function with only 7% of late new onset diabetes and no disease recurrence. So thank you for your attention.
Thank you. Thank you, Anna. I don't see any questions in the chat. I will wait a little bit longer because it takes some time.
Yes, first, it's really a pleasure to see you. Really.
Thank you.
I was virtual, but hoping to see you soon. Looking forward to see you soon in person, for a personal meeting, EPC again.
Yes, next year for sure. Well, given the time and when there are no questions, the talk was very clear. Maybe, Roberto, you can introduce our last speaker.
Yes, we go further, and the next speaker is Ludmila Pererva that will talk about extended pancreatectomy in treatment of patients with pancreatic cancer. She will present their experience.
Dear colleagues, I would like to tell thank you for invitation and for the opportunity to present our report about extended pancreatectomy in treatment of patients with pancreatic cancer. My name is Ludmila Pererva. I don't have any relevant financial relationship to disclose. According to the National Cancer Registry of Ukraine, the number of patients with pancreatic cancer in our country increased over time. Unfortunately, most patients at the time of diagnosis have distant metastases, borderline resectable, or locally advanced pancreatic cancer. Extended pancreatectomy is the only option for recovery or long-term survival for patients with pancreatic cancer with involvement of adjacent vessels and organs. 645 patients with pancreatic cancer had radical surgical treatment in our department in the Shalimov National Institute of Surgery and Transplantology for the period from 2009 to 2019. The number of men was higher, average age was 57.7, from 22 years to 81 years. Extended pancreatectomy was performed in 149 patients. Standard pancreatectomy was performed in 496 patients. We compare the results of extended pancreatic resection for 2 periods after implementation of new methods and treatment tactics developed by us and before. These groups were comparable by tumor stage. Extended pancreatoduodenectomy was performed in 82 patients, external distal pancreatectomy in 56 patients, and external total pancreatectomy in 11 patients. We performed 104 resections of vein. We divided venous resection according to International Study Group for Pancreatic Surgery. On this photo, you can see type A, type B venous resection with use of venous patch, autovenous patch, type C and type D. On this photo, you can see circular resection of portus mesenteric confluence followed by end-to-end anastomosis with autovenous graft from the left renal vein. Extended pancreatectomy with arterial resection were performed in 11 patients. It was different type of arterial resection. Modified Appleby procedure was performed in 6 patients. On this photo, you can see modified Appleby procedure with additional resection of portal vein. In patients with pancreatic cancer of the body and tail, we performed radical integral modular pancreatosplenectomy. Rams posterior was performed in 26 patients. In all patients, we performed a modified extended lymphadenectomy with remove of extrapancreatic nerve plexus around the right side of an SMA in patients with pancreatic head cancer and around the left side of an SMA in patients with pancreatic cancer of the body and tail. For determining safety and feasibility of extended pancreatic resection, we compare surgical result of extended and standard pancreatic resection. Average blood loss, frequency of complications, and average hospital stay were comparable in these groups. Average operation time was higher in patients after extended pancreatoduodenectomy and after extended pancreatic distal resection. What about postoperative results? Morbidity and mortality were comparable in two groups. Postoperative complications were significantly higher in patients after extended pancreatectomy with arterial resection. In patients with venous resection, we did not find any significant difference. Postoperative pancreatic fistula, delayed gastric emptying, and hemorrhage were comparable in two groups, after standard and after extended pancreatic resection. The most serious complications after pancreatic resection is postoperative pancreatic fistula. To prevent this complication, we investigate risk factors that influence of occurrence of postoperative pancreatic fistula. According to our data, sarcopenia and postoperative hemorrhage significantly influence on the occurrence of postoperative pancreatic fistula. In all patients before surgery, we studied presence of absence of sarcopenia. We used Hounsfield unit average calculation. In patients with sarcopenia, we used specialized nutritional support and exercise before surgery. To reduce intraoperative blood loss, we use SMA first approach. With mobilization of Usinat process during pancreatoduodenectomy, with all ligation of the IPDA and vessels to the pancreatic head. This technique allowed us to significantly reduce intraoperative blood loss. Mark Kellery developed pancreatic fistula risk score. In our opinion, the assessment of pancreatic density according to the criteria of soft and hard is subjective. We found that the pancreatic density correlates with the presence of pancreatic fibrosis. We proposed a method for determining the density of pancreatic remnant tissue, defining the presence of pancreatic fibrosis in the pancreatic specimen during intraoperative microscopic examination. If the level of fibrosis was less than 15%, this pancreas was considered to be soft. If the level of fibrosis was from 15 to 30%, this pancreas was considered as moderate density. If the level of fibrosis was more than 30%, this pancreas was considered as hard. We developed our modification of pancreatic fistula risk score and our surgical tactics. In patients with high risk of pancreatic fistula, we performed pancreatojejunostomy with external drainage of the main pancreatic duct. In patients with intermediate risk, invaginative ductal mucosa, pancreatojejunostomy. In patients with low risk, anastomosis for consideration by operating surgeon. In comparison group, in patients we did not assessment of the pancreatic fistula risk and presence of sarcopenia. In this group, decision of the type of pancreatic anastomosis was based on surgeon preference. On the slide, you can see pancreatojejunostomy with external drainage of the main pancreatic duct. Since these tactics, we significantly reduce the level of postoperative pancreatic fistula, significantly reduce the level of morbidity in patients after pancreatoduodenectomy without mortality in main group. Thanks to implementation proposed method and surgical tactics, we significantly reduce the level of postoperative complication from 47.9 to 31.6% and increase mortality from 5.5 to 1.3%. Our personalized diagnostic and treatment algorithm allowed us to increase the median survival of patients after extended pancreatic duodenectomy from 15 to 22 months and 5-year survival from 20 to 25.5%. On this slide, you can see our conclusions. Thank you for your attention.
Thank you very much for such a nice presentation and such nice pictures and excellent data, actually. We have one question from the audience and is asking, what is your preference for portal tract replacement after a Whipple procedure?
May you repeat questions, please?
What is your preference for a portal tract replacement after a Whipple procedure?
Portal tract
replacement.
We did not perform these techniques. We performed venous resection during pancreatic duodenectomy.
Okay.
You know, I introduced our tactics on the slide. We perform different types of venous resection and reconstruction after that.
Okay. I have one question. When you perform the extended lymphadenectomy, do you usually perform that in block or?
Yes, thank you for the questions. And we usually perform en bloc lymphadenectomy with main complex.
Excellent. Thank you.
Thank you. I think this brings us to the end of this session. There's an airplane flying over now. We have that in Amsterdam. I'm sorry. Thank you to the speakers and also all the participants, and a special warm greetings to all our friends in the Ukraine. Don't forget to hang on, because next there's a panel discussion on pancreatic tumors, and thank you for joining us today. Thanks.
Thank you. Bye.
And thank you, Roberto.
Bye.